I have with me Dr. Praveen Chandra from India, Delhi, Medanta Hospital. He's one of the leading interventional cardiologists in India. So we just performed a TAVR procedure on a patient and it went very successfully. And so we are just sitting here to discuss about TAVR in Sri Lanka and India. Dr. Praveen Chandra, so you have performed a large number of TAVR procedures in India. Looking back, what has changed most in the way you select patients today compared to when you started?
Okay, very good question. First of all, thank you very much for having me here. We really enjoyed doing this procedure in a very proper way, and thank God that everything went off very well. Now the thing is that this has been a journey of more than about, I will say, 13-14 years. When we started this, it was very difficult to do the TAVR procedures at that time, because there were not enough sheets, not proper wires, etc. Now everything is custom made. We have the proper insertion sheets, proper wires, proper sizing tools, everything. And also we have a very big array of sizing of the valves. So we can accurately size the valves. That is why now we are able to do these procedures in a very short time. Okay. Earlier it used to take about 2 hours, now it takes half an hour, 40 minutes.
So we once thought of TAVR mainly as a treatment for elderly, high-risk surgical patients. Are we now reaching the point where TAVR is becoming the default treatment for severe aortic stenosis, even younger people?
Yes, to a certain extent, I must say. We started doing TAVR procedures for elderly patients, very elderly patients. Then we started doing in slightly younger patients, like going from 80 to 70 and now from 70 to 65, and many times we even do it in more younger patients where surgery has been done earlier, like a previous bypass surgery patient or a high risk patient for surgery. These are the indications today for younger patients.
How do you choose between a balloon expandable and self-expanding valve? Choice becoming more patient specific than ever?
Yes. We have a very patient, because earlier it was only many times self-expanding valve, then we had also balloon expandable. Now we have a very wide range of these valves which are available. So today we individualize our choices to each individual patient to get the best outcome.
So for an operator developing a TAVR program, what is the single most important technical lesson you wish someone had taught during your first 20 cases?
Yeah, so basically the most important thing is that everyone should know the steps of doing the TAVR procedure. So if the whole team is ready, so it's a teamwork.
Yeah.
So if the team is ready, everybody knows what is to be done, then it is a very, very quick and simple procedure. Even lesser time than angioplasty.
So what are the complications you mostly encountered?
Yeah, the complications can be sometimes, patients need pacemakers after the implantation. So at times there are local vascular complications. These are the two ones. But sometimes it can be a very dangerous complication of perforation or rupture of the aorta, patient having stroke. So those are much more dangerous complications. But fortunately, the new experience and with all the the new hardware, it is very rare now.
What is your current view on durability of the valve?
The durability of the valve has also improved with the newer iterations of the valve, and typically I see that most of these valves are at least working more than 10 years or 12 years or going even up to 15 years. It's as good or even better than the surgical valve.
For countries such as Sri Lanka, where resources and procedural volumes are different from major international centers like in India, what is the safest way to build a sustainable TAVR program?
I mean, the safest way is to first, of course, arrange everything and do the procedure safely. These patients who are really needing it definitely should be selected properly. Okay. Patient selection is the key to success.
If you had to give a message to younger interventional cardiologists in Sri Lanka who are entering structural heart intervention like TAVR today, what it would be?
My advice is that these young interventional cardiologists should first do a 1 or 2 year training and become very, very familiar with the cath lab procedures, like doing angiography, interventions, measuring pressures, everything. Once they are absolutely ready with that, then only they should start thinking of learning the TAVR procedures, because then it becomes very easy. And learning TAVI is not so difficult, and if you learn the right steps, it will be not so time taking also. Generally 3 to 6 months of training is good enough.
Thank you very much
you.
for coming all the way from India and then helping us with this case.
Thank you.
Thank you very much.
Thank you.